We are going to get started with our grand rounds this morning. If you don't know me, my name is Erica. I'm one of the residents here, and I have the privilege of getting to introduce a couple of my favorite ladies this morning who are going to be presenting some really interesting cases for us for our grand rounds. Our first speaker is Nigussie. She's a PGY2 resident here at the Moran Eye Center. And for both of these fabulous people, I asked them to tell me something adventurous that they had done. And one of the most adventurous things they had done, and Dr. Nigussie told me that one time she visited Morocco and unfortunately got lost while hiking in Morocco, but managed very skillfully to use Google Translate with just the little sliver of service that she had to find her way back to civilization, and now allowed her to be with us here today to tell us all about this really exciting talk that she's going to give that's titled BBs and Beyond, Unexpected Visitors in the Orbit.
All right. Hey, everyone. My name's Eamon, like Erica mentioned. Really happy to be here, especially excited to share this day with Maddie, who is one of my favorite people. So my title, BBs and Beyond, Unexpected Visitors in the Orbit. I have no financial disclosures. This is kind of an overview of how the presentation is going to go. We're going to go over a case presentation, talk about orbital foreign bodies, their management, and then key takeaways at the end. So for history, this is New Year's Day, 12:03 a.m. I just got into bed. I got a page from PCH, which is always a delight. And I called the provider. She tells me that there's this 15-year-old male in the outside ED. He just got a right eye trauma from a BB gun injury. They did CT scan over there. They noted a BB pellet inside the orbit. It was near the optic nerve. He didn't note any vision changes. They gave him fluids, antiemetics, antibiotics, and then sent him to PCHED for further evaluation by us. He was actually life flighted and still ended up taking 2 hours to get here. So when I first saw him, he was with his mom. He told me that he was at a friend's house New Year's Eve hanging out. He was coming around a corner and unfortunately got shot by one of his friends from 20 to 30 yards away. He didn't lose any consciousness, but it was really painful, obviously stressful situation, almost fainted, but still knows that his vision is at baseline. However, on the affected side around his nose, he notes a dark spot, denies any diplopia, any other vision changes. And then this family was actually like very astute, had a lot of information with them, starting from how far away he was when he got shot to the type of BB pellet that was used. And this was it depicted right here. And it makes sense why, they had a lot of information. His history's not really contributory other than the fact that he's actually a competitive trap shooter. Word on the street is that he's 5th in the world, and he's right eye dominant. So on top of everything that was happening, this was particularly stressful for both him and his family. So regarding his exam, he's 2025, near card correction, corrected to 2020 with pinholes. I was unable to do color plates because he was colorblind at baseline. Visual fields were full to confrontation. EOMs were also full, although very painful throughout all gazes, especially laterally. Intraocular pressure normal as well. For his slit lamp exam, the most notable aspect was that he had a very dense subconch heme temporally. And then at this point, there's also darkly pigmented speck embedded in the conjunctiva versus the versus the sclera. And I actually wasn't sure if it was like a lot deeper, if it was uveal tissue, if there was any sort of glow compromise. Otherwise, the rest of the eye actually looked pretty good. His cornea looked absolutely okay, other than a few PEs. the interior chamber was also clear, no cells. And this was his EOMs. And I actually really like this series of pictures, actually screenshots from a video, because not only does it depict that his EOMs were full, but you can see a clear distinction that the temporal subconchine was just like a straight line in the middle, and then temporal, and you can see some ecchymosis and edema on the lower lid as well. And this was my attempt at taking the picture of the foreign body. Fortunately, you can't really see it super well, but if you can imagine with me, there was potentially metallic foreign body embedded there. And this was another picture I took with my iPhone 15. This is fundus exam, so depicted very dense vitreous hemorrhage temporally as well as inferiorly, and some pockets of subhyaloid hemorrhage as well. Obviously very diffuse commotio, but there was concern for globe compromise. I obviously did not depress him. There was no overt tear detachment. And in the left eye, there was a longstanding macular scar that was just kind of an incidental finding. So for his CT scan, when I was going through it when he was on the way here from the outside hospital, obviously the main concern for me was that is the globe intact, is it ruptured? And from this, you can see it's fairly intact. There's some air pockets, fluid there, but as we go more inferiorly, you can see the BB pellet very comfortably located there inferiorly. And then on the coronal view, again, more air pocket fluids, and then there's the BB pellet along the lateral aspect of the inferior rectus there. And then I really like this sagittal view because it kind of shows us a great view of the potential trajectory of the pellet, where it entered like inferiorly from the palpebral conch through the septum and just made its way home in the posterior orbit there. So as a summary, previously healthy 15-year-old have a copper-plated BB pellet lodged on the posterior orbit with associated concern for potential open globe injury with dense vitreous hemorrhage. As mentioned, eye vitals are reassuring, and then the other exam findings are as below. So for his clinical course, at this point, he had some concerning exam findings, and the decision was made to perform globe exploration, just to make sure that there was no over perforation. Even though it was a low likelihood, there were some signs that were concerning. And another, I guess, fork in the road was there's this BB pellet and the posterior orbit. It seems like his vision's fine, but he's already getting anesthesia. Likelihood of potentially getting an MRI maybe sometime in his lifetime. Should we try to get this BB pellet out? Should we not? And then the decision was made to at least try to attempt. If it's too difficult, we'll leave it. If not, then, that's a success. After we found out that there's no globe perforation, we wanted him to see retina to make sure that he didn't have any occult tears or detachments. So after much effort, the BB pellet was extracted, and this is Sudi holding it. They actually ended up using a quote poop magnet, which unfortunately I was not able to get a picture of, but you can use your imagination. So regarding his post-operative course, next day he saw retina, some diplopia, some EOM restriction to be expected considering he had some, traumatic globe exploration, if you will, but there was no retinal tear or detachment on SDE. They plan to observe this heme without any operative management. He saw oculoplastics a few days after, still doing really well, and then retina again. At that point, vision's good, but he's noticing some floaters or blood spots around the center of his vision. This is the picture they took during the clinic at that point. It seems like the heme is kind of dispersing more centrally. Unfortunately, I was not able to put this in my PowerPoint, but he was actually seen in clinic yesterday in retina. He's still doing well. The vitreous hemorrhage is still clearing. They're still gonna follow him non-operatively. All right, so overall, orbital foreign bodies, what are they? So any sort of object that's located in the orbital cavity outside the orbit, behind the orbital septum, is what we consider an orbital foreign body. They constitute about 20% of all orbital injuries, and unfortunately more common in young men, and most of the time it's due to high velocity injuries. So why do we care about them? Obviously, they're very vision threatening, whether it's due to globe perforation or traumatic optic neuropathy or even other complications. The other consideration is, especially organic materials have a high risk for infection and severe inflammation. This picture on the right, it was a patient Dr. Kirsten saw a few years back. He just presented with, just orbital cellulitis type of presentation, some erythema, edema, and some discharge, but he ended up having some wood in the anterior orbit that they were able to safely and successfully extract. And then the last point is chemical toxicity. So when I first saw this patient and I ended up realizing that he had a copper-plated BB pellet inside the globe on it, my main worry at that point was like, oh my gosh, is this going to be like toxic long term? And I'll touch upon this a little bit later, but it turns out not as much. But because it's a very strong consideration for intraocular foreign bodies, I think that's also something we should think about for intraorbital foreign bodies. So what can be lodged in the orbit? Turns out a lot of things. So the top row over there, there's wood, glass, lead in the form of a pencil. The bottom row, just like our patient, there's a BB pellet, a knife, and then also a bullet. There was a study done in China that was published a couple of years ago. They looked at about 100 patients in a span of 10 years, I believe, and they found that the most common orbital foreign body, as expected, is metal, mostly iron, followed by wood and then inert materials. And just very quickly about BB pellets. I know more about BB pellets than I wanted to this after doing this presentation, but they're very small, don't weigh a lot. And I was just kind of curious why they're more likely to be coated with copper nowadays. And it's because it basically helps the steel last longer. And this is a picture of an unfortunate situation where it was lodged in the optic nerve and required enucleation. So when you see someone with an orbital foreign body, main thing, the history is obviously like any sort of ocular injury, really important. You want to figure out the mechanism of injury, when it happened. Neuroexamination, really helpful to, know if the globe is penetrated or not. Sometimes it's not as obvious as this picture right here. They might present with proptosis, or like the patient I showed a couple of slides back, they might present with an infectious picture. Anytime we see these patients, before you think about any sort of management, considering anti-tetanus prophylaxis, as well as systemic antibiotics, is also really helpful. So for diagnostic workup, obviously CT scan, especially if we think that this is a metallic foreign body, is the gold standard. However, MRI is actually really great at detecting non-metallic foreign bodies, especially wood. This is another patient Dr. Kirsten saw a few years back. He was just outside playing, fell, and then presented with a very benign looking appearing globe, other than some erythema, but unfortunately he did not have great vision at that point. The CT scan didn't really show much other than some air pockets, and then in the picture of the MRI, you can see there's a stick through the optic canal. Unfortunately, that ended up dissecting his ophthalmic artery and compromising his vision. And this is the intraoperative picture of the wood lodge there medially. And then ultrasound also really helpful for real-time imaging. And then usually lab tests if you're concerned about sepsis or maybe some systemic lead toxicity at times, although it's like very low likelihood with intraorbital foreign bodies. Those are other considerations. And just a few words on calcosids, which again, like when I mentioned in the beginning, that was what I was personally most worried about when I came across this case. But overall, copper, it has a deposition or it has an affinity for basement membrane. And I didn't know this previously. It really depends on the content of the copper. If it's over 85%, studies show that it's generalized deposition, really strong inflammation. It's like endophthalmitis-like. If it's less than 85%, it tends to be more of a localized deposition and indolent course, and it's the typical cause of calcosis. And this is a patient with an actually intraocular copper containing foreign body, ended up with some macular depositions. So finally, I want to talk about management. There's a few studies that I thought were really helpful when trying to decide about what to do with intraorbital foreign bodies. The first one was a study done in Australia, and most of these were actually published in the late 90s to early 2000s. They looked at about 40 patients, and I really like this one because it kind of gives you a flow chart of when to decide to perform surgical management for these patients. And the main thing that they ended up with was where is this foreign body located? Is it posterior? If it's posterior, there's a higher risk for infection, or sorry, a higher risk for surgical complication. Therefore, that's definitely a really strong consideration. And then what is the material? Ends up being like we all know, organic materials tend to cause a really high risk for both infection and a very strong inflammatory reaction. So you meet a patient with intraocular foreign body, you assess them, you image them, you cover them with anti-tetanus therapy, antibiotics, and then there's a fork in the road between inorganic and organic material. If it's organic, likely needs to come out. If it's inorganic, another fork in the road. Is it anteriorly located? Is it easy to get? Or is it posteriorly located? If it's anterior located, likely you'll take it out. If it's more posterior and not causing any complications, actually the surgical removal is not really indicated. So main takeaway for this study is that anti-tetanus therapy, antibiotics, and remove it if it's organic, and then leave it if it's posterior. And then the next study was done at University of Tennessee. Actually, they looked at about 50 cases, 20 of them were metallic. 9 of those were located posteriorly. Majority of these patients remained to have really good vision, and the 3 of them ended up needing surgery, and the classification for requiring surgery was, the first patient needed MRI for something completely different, therefore they needed to extract it. And 1 had mechanical strabismus and 1 ended up having a sterile abscess. And then I also really enjoyed reading this study because they looked at the different metals that could potentially cause toxicity, specifically in the intraorbital foreign bodies. The first one was iron. They said that the degree of damage is actually mostly related to the size and as well as the contact with sclera. Otherwise, the risk of cirrhosis is actually fairly low. The second metal they looked at was lead. Again, there's like very minimal evidence of systemic intoxication with intraorbital foreign bodies. And lastly, but definitely not least, they looked at copper, which is overly not super well tolerated, but the higher risk of complication is actually related if it's pure copper versus if it's like a coating, like a BB pellet. And they kind of alluded to the fact that, you know, we can likely safely leave, you know, copper if it's not, you know, if it's like, for example, a BB pellet that's coated in copper. And then if you want to be extra careful, they suggested that you can potentially consider using ERG to note any sort of early retinal damage so that you can take it out. Again, main takeaway for this study was that retained metallic foreign bodies are typically well tolerated, unless maybe it's copper, but overall, patients actually end up doing really well. And then the final one is a study done at Mass Eye and Ear. They looked at 27 cases, 20 of them were BB pellets, 10 were posterior, 2 were removed because of complications. And I kind of want to highlight one particular case, which is very similar to our patient that I saw with several other doctors here. And it was a 9-year-old BB pellet. Those shots about 20 feet away. He was doing okay. His fundus showed some commotio as well. And they basically gave him 7 days of IV antibiotics and no further intervention after that. And presumably he's doing really well somewhere out there. And main takeaway for this is just leave posteriorly located metallic foreign bodies because of the really high risk of surgical complications unless there is evidence of inflammation, infection, or potentially nerve impingement. And then finally, for the key takeaways, main thing, don't give your teenage son a BB gun, a very high-risk population. And then the second one is if it's organic, likely it must come out. And then the third one is it's likely safe to leave metallic foreign bodies, especially if they're located posteriorly because of high risk for complications. But obviously with the advent of, you know, potentially everyone needing MRIs in the future, that's, you know, another consideration in the decision making outside. These are my references. Thank you to everyone who's involved in this case, especially thank you to Dr. Kirsten who let me borrow some of his pictures. Thanks, everyone.
All right, let's all thank Dr. Nigussie for her fantastic presentation. The next speaker we have today is Madison Perchik. She's also a PGY2 resident here at the Moran Eye Center. When I asked her about something adventurous that she had done, she tried to convince me that she's never done anything adventurous, and I told her that was a lie. And so finally, she told me that filled with inspiration by the great people on the Great British Baking Show, she one time attempted to make French macarons. This is a common feature on the Great British Baking Show. For anyone who doesn't believe that this is an adventurous activity, I want you to consider to yourself all of the life-threatening things that you would potentially agree to do prior to attempting to recreate anything on the Great British Baking Show. So I think that this is a fabulous thing. And she is going to be talking to us today about Out of Alignment, the Portrayal of Strabismus in Children's Media.
Thank you, Erica. And French macarons are very, very difficult to make. And it felt like an adventure to me, and I'm probably not going to do it again. So again, I'm here to talk to you guys today about strabismus in children's media. And I did want to start out with a quote. And so the quote is from Nelson Mandela, and it says, "No one is born hating another person. People have to learn to hate. And if they can learn to hate, then they can taught to love as well." Excuse me. And so I just love this quote because it's kind of the intention behind my talk today. And the inspiration behind my talk was a patient that I met in Dr. Vigunta's clinic a couple months ago. And he was a teenage boy. I don't know if he had a BB gun, but he was a teenage boy and he had noticeable exotropia. And this was the first time he had seen an ophthalmologist. He was about 16. And when I met him, his eye with the noticeable exotropia was shut. Completely shut. It was actually very hard for me to get measurements on him because he had shut his eye for so long and he had grown his hair over that eye that it was hard for him to keep both eyes open. And parents and him said that that's just kind of how he had lived his life for really as long as they can remember since he was a little kid. So I started to think about, what things in our society kind of forced him into this closing one eye and being so self-conscious that he felt like that was the best way to kind of navigate through society. So this is kind of the roadmap for my talk today. So I'm starting with the strabismus overview, then I'll go into the psychosocial effects of strabismus, then move into media and children's development, and then I will end with the fun part, strabismus in animated movies. So strabismus affects about 2 to 5% of kids, which is roughly 1.5 to 3.7 million kids just in the US. And this can be caused by uncorrected refractive error, problems with neuromuscular control of extraocular muscles, or extraocular muscle pathology itself. There are many risk factors. So some of the risk factors are prematurity, family history of strabismus, exposure to substance use or smoking in utero, trisomy 21, hydrocephalus, cerebral palsy, poor vision in one eye, or trauma. And strabismus can lead to lack of binocular fusion, diplopia, amblyopia, and psychosocial issues. My talk today is really focusing more on the psychosocial side, the effects of strabismus, but I did want to recognize, of course, that there are strong visual impacts of strabismus as well. So here are some of the AAO preferred practice patterns for esotropia and exotropia. So the treatment recommendations, and these are specific, to certain types of esotropia and exotropia, but treatment options are correcting refractive errors, bifocals in certain situations, prisms, patching, extraocular muscle surgery, pencil push-ups, and even Botox injections. And the AAO preferred practice patterns do speak pretty in depth about the psychosocial effects of strabismus, and this is just kind of a highlight. But they said, misaligned eyes may limit employment opportunities due to stigma and bias, and they also say that ocular alignment can lead to more positive social interactions through more self-confidence and also better maintained eye contact. And the AAO recommends surgical intervention before age 6 for strabismus, and part of this recommendation does come from the psychosocial effects that strabismus can have after this age. So when I read that, I started thinking about what research do we have that has kind of created that age cutoff, research on 3, 4, 5, 6-year-olds, what does that look like? So I will kind of go over some of the kind of more landmark studies on this topic. So after reading many studies on this topic, this is kind of the general psychosocial effect that I was able to find. So strabismus can lead to social isolation, loneliness, decreased quality of life, and potential mental health issues for our patients. So the first study that I'm going to go over is a study out of Switzerland. This is a very, very commonly cited study. And they digitally altered pictures of 6 children, and they made identical twins. The only difference between the 2 pictures of the created identical twins was that one twin had strabismic eyes and one had orthotropic eyes, and then they changed the shirt colors between the 2 twins as well. They had 118 kids aged 3 to 12, and they asked these kids to choose which twin they would prefer to ask to their birthday party. And kids less than 6 years old had no distinction between which twin they offered an invite to their birthday party. And kids age 6 or older significantly or invited the strabismic kids significantly less often. And interestingly, the 4 to 6-year-old age group did notice a difference between the orthotropic and strabismic eyes, but they didn't know that this different, or they didn't note any kind of negative feelings toward the difference. They just noticed that they were different. And this study also commented on the percentage of kids that commented on the eyes being different in different age groups, which I found interesting. And there was an increase in the percentage of kids in each age group that commented on the eyes. And the investigators asked a general question to the kids and said, do you notice anything different between the twins? The 4 to 6-year-old age group mentioned eyes 19% of the time, the 6 to 8-year-olds 48% of the time, the 8 to 10-year-olds 83% of the time. So by the time they're 8 to 10, most of the kids were saying that the eyes appeared different on a general question. And kind of some quotes that they got from the kids were, the eyes were crossed, stranged, turned, squinting, looking in different directions, looked like chameleons, or different from one another, or they weren't straight. So additional studies on this topic. The first study comes from Baylor. They looked at just 5 to 6-year-olds, so a smaller age group. They had 128 participants, and they did a similar thing with pictures. So they had, people, faces with orthotropia or orthotropic eyes, and then faces with exotropic eyes specifically. And they asked these, small children which picture they liked better, and then which one they would rather share their favorite toy with. And 63% of these kids 5 to 6 years old like the orthotropic faces better, and 61% preferred to share their toys with the orthotropic faces. The last study that I'm going to mention on this topic comes out of Malaysia, and this one is also very, very commonly cited. Even though it's a small sample size, it's cited in the AAO practice patterns as well. They used dolls instead of pictures, so they had strabismic eyes on one set of dolls and orthotropic eyes on one set of dolls. And these kids were 3 to 7 years old. The investigators watched them through kind of a one-way mirror situation, or I guess that's what's called, one-way window. And they kind of scored their interaction with the dolls as negative or positive. And then they also interviewed the kids afterwards and asked which doll they liked better. And again, this was only 34 children, but they did find that age 5 3/4 or older kids were 73 times more likely to report a dislike of the strabismic doll compared to the younger kids. So the 3 to 4-year-olds really didn't notice a difference between the dolls. And similarly to the other study that I mentioned, the 4 to 5-year-old age group did notice the eyes as different, but that difference wasn't negative, it was just different. And then once they became kind of that 5 3/4 age, they did significantly prefer the orthotropic dolls. So moving on to kind of the quality of life and mental health issues that can be caused by strabismus, I have 2 studies to talk about on this topic. So the first study comes out of Southern California. It was a population-based study of 2 to 6-year-olds. And this comes from a large survey set of, it's called the PEDS Quality of Life Inventory. And they identified 121 kids with strabismus. And they looked at the scores of this survey that parents filled out. And the kids with strabismus, their scores were significantly lower in the general health related quality of life scores. And these topics were included areas of physical, emotional, social, and school functioning. And really interestingly, the impact was the same for intermittent and constant strabismus. And also the PEDS quality of life scores were no higher in the strabismic kids with stereopsis versus strabismic kids without stereopsis. And these associations existed even after controlling for things like gender, age, ethnicity, family income level, and things like that. And so you could also obviously think, of course, quality of life is going to be different if you don't have binocular vision or you have diplopia or amblyopia, these things. But because the impact was seen for both intermittent and constant strabismus, and the scores were no higher in the strabismic kids with stereopsis, the investigators in this study were kind of concluding that it's very likely that the cosmetic misalignment was really to kind of blame for these lower quality of life scores. And the next study on this topic is more of the potential mental health issues. And this was a very large multi-center study and at a larger age range as well. So the cutoff was less than 19 years of age. And they looked at de-identified insurance claims, and they had over 350,000 children that were identified with strabismus. And they were looking for associations between strabismus and other conditions, and they found a significant association between strabismus and anxiety disorder, depressive disorder, bipolar disorder, and schizophrenia. And again, these associations were still present before and after adjusting for age, sex, race, ethnicity, census region, education level of the caregiver, family net worth, and even the presence of a comorbid condition. So moving on to the media and children's development of biases, I think this study is really fascinating. It came out of the University of Washington, and they concluded that television shows and movies can affect children's development of biases from as young as 4 years old. And so their first experiment, they took 67 preschool children. They exposed them to a brief video that had 3 characters in it. So there was a main character and 2 targets. So the 2 targets were given a toy by the main character, and the main character starts doing positive or negative nonverbal cues consistently to one target or the other target. So one target only got positive nonverbal cues, the other target only negative nonverbal cues. And then they asked these 67, preschool kids, which of the two targets do you prefer? Which would you like to share your toy with? And this was just a brief video that they were shown. And they showed the kids significantly preferred and wanted to share their toy with the target with the positive nonverbal cues. So that was kind of a taught bias that they had just learned from this video. And they did another experiment where they wanted to see if this bias could be generalized. And so they now gave the two targets best friends. And so the positive nonverbal cue target had a best friend, the negative nonverbal target had a best friend, and they asked the same question, which of the best friends of the targets would you rather share your toy with? And again, the bias was able to be generalized to the best friend. So the best friend of the positive target or the target with positive nonverbal cues, the kids chose significantly more frequently. And I have to mention screen time as well to kind of show that, if we're saying that now, we can influence kids with these biases as young as 4 years old, how much screen time are kids having? And these aren't even the most updated numbers. It's the most updated I could have, but some of them are from a few years ago. So I would venture to say these are even more than I'm reporting. But kids 8 to 18 have 7+ hours of screen time daily on average, and preschoolers have about 4 hours. And I thought this sounded ridiculous until I thought about all the different screens we have. And so this includes, smartphones, tablets, televisions, computers, video games, all of these things. And so then I started to think about my own screen time, and I was like, oh, okay. And then 71% of 8 to 18-year-olds have a television in their room, which I found very interesting. And 80% of households with children have tablets. And then lastly, children begin to comprehend child-directed television starting at just 2 years of age. And interestingly, at that age, it can be a positive or negative effect. There were some studies with some positive things, so it's not all negative, but just interesting to think about, if they can start understanding things at 2 and maybe start learning biases at 4, and we're having 4 hours of screen time a day, that's just a lot of opportunity for media to be influencing our children. So now to a fun part. So strabismus in children's movies. So these are some examples of characters that I've seen in movies that have noticeable strabismus. So kind of going from the top left, we have Ursula's eels in The Little Mermaid. Going down, we have Ed the hyena from Lion King. We have Hey from Moana, Darla from Finding Nemo, Boo in her costume that has strabismus from Monsters, Inc. The guy on the right over there is from Princess and the Frog. He's the frog catcher. And then Iago from Aladdin. So, I don't know if this movie is going to work, but we will see.
What do you think, Aaron? Hey, we already had. It's not fun, and you got.
All right. So, although I do really like watching animated movies, I just wanted a short clip kind of to show an example of what I'm going to be talking about. So, things that I notice in Ed that are different from his kind of other hyenas. Of course, being in ophthalmology, the first thing I notice is that he has eye misalignment, whereas his fellow hyenas do not. Other things that you might have noticed is that he's kind of a comic relief. He laughs, but he does not speak. His tongue is hanging out, he's clumsy, and he's definitely not really the leader of the pack. So I have one more short example, Darla from Finding Nemo.
Did I not? You're gonna be okay.
So, as you can see, while Darla is just a little girl, in this movie, she is kind of a little bit of a villain. And so you can see that, Nemo's trying to not go belly up because she's known for shaking the back a little too hard. And there's kind of even scary music around her, and they kind of scream when she comes in. So she's not like the most positive character in the movie. So, going into this study that I wanted to talk to you guys about, because this has been studied, Dr. Michael Puente, who's from Colorado, who was just here a couple months ago giving a grand rounds, he was kind of the attending over this study, which I really think is awesome. And Jin Tong Liu is one of his students that was working a lot, and then they also had other contributors. But this is some of the coolest research ever because they watched 125 animated movies. And they identified 46 characters with strabismus, and these were from all different movie studios, including Walt Disney, Studio Ghibli, Pixar, DreamWorks, and they're from a period of 1989 to 2022. So it's not just, older movies, it's movies that just came out as well. And so, unfortunately, they found that characters in movies that have strabismus were more likely to be portrayed negatively. And, Darla and Ed are kind of two examples that I thought most of us would kind of remember from movies that kind of portray that. But they found that 30% of these characters were unintelligent and compared to 2% intelligent. 15% were portrayed as villains rather than 4% as heroes, 41% followers, and 7% leaders. Only 2 were primary characters, and they were both villains. And all the other ones were either secondary or peripheral characters. 58% of these characters were either mute or did not speak. 24% were portrayed as frightening, 35% had other physical abnormalities, and then 35% were portrayed as clumsy. And forgive me, I didn't tell you how they kind of did this, but they had 5 raters that kind of went through all of these characters, and they had different characteristics in a scale, and they averaged together the scores that these raters gave them. So I did want to go into the characters that were leaders and then also the ones that were primary characters. And it's interesting because I only know one of these characters, but 3 of them were leaders. One of these leaders was a villain, and it was the Cat's King from Studio Ghibli's The Cat Returns, and that's the picture on the bottom right. And one of these leaders was unintelligent, which is Scuttle from The Little Mermaid. And then one of the leaders was a peripheral character, but he was the only character with strabismus that was rated to be intelligent. And that is the character, the Good Dinosaur, in The Good Dinosaur named Forrest Woodbush. And that is the character up on the top right, because I haven't seen that movie yet. Now I need to. And then 2 were primary characters. One was that character that I mentioned already that was the leader, that was the villain, the Cat's King. And then the other was Dave the Octopus from Penguins of Madagascar. So this study kind of concluded that, children can internalize biases, that people with eye misalignments are, negative characteristics, such as they could be less intelligent, they could be evil, they could be frightening, they could not be leaders, or they could be clumsy. And of course, I want to mention that media isn't the only source of social stigma, but it is one that can be intervened upon and improved upon. So my conclusions for today are that strabismus can cause negative psychosocial effects in children as early as 5 to 6 years old. TV and movies contribute to children's worldview, including learned biases from preschool age on. Strabismus reflected in children's media may influence kids to associate eye misalignment with negative traits, whether that's in themselves if they have eye misalignment or in their classmates. And because of all of these conclusions, it's really important for us as ophthalmologists to advocate for positive representation of physical differences such as eye misalignment and to combat this social stigma. And thank you very, very much. And I wanted to send a special thank you to Dr. Bagunta for working with me on this presentation. Any questions?